Very good afternoon to all of you. And as we were envisaged earlier, Saturday is a very, very busy schedule, and so we a bit delayed for the event. We actually thought of starting at registration at 12:45, and we scheduled to start at 1 o'clock our scientific session. But hopefully, we expect to have some more delegates come as promised. So we'll take it forward as it comes. As you are, most of you are aware, this is our first CLE program with Gadut Private Hospital. This is a vision of few medical as well as non-medical investors. We started the dream of setting up a very quality healthcare facility in the region. And as our CEO says always, hospital with the character to provide a very quality healthcare delivery to the people of the region with a very affordable. And to a certain extent, we've been able to meet those visions, and we are very happy to see that people have actually, a certain level, accepted our the way of functioning, the kind of delivery, healthcare delivery, what we have provided to the people of the region. We started exactly 4 months back. The referral community has been very promising, and we continue to look forward to have your support and in helping us in providing a quality healthcare to the region. I request Dr. Neil, our interventional radiologist, and Dr. Mohammed Ghanem, our CEO, to give a few words to start with.
Okay. Thank you. Okay, good afternoon, everyone. I'm Dr. Ghanem. I'm the CEO of the hospital. As you all know, Gadut Private Hospital is a new hospital. We just started, as Satish said, 4 months ago officially, but we've been practicing, or we've been operating 6 months ago. It's a small hospital, but a hospital as I always say, a hospital with a character. We'd like to keep it that way. I think we are starting our CME program today, which is a good occasion actually to start a CME program in the occasion of the World Heart Day. And I hope you find it useful and beneficial. I'd like you, if you have time after the end of this function, if you have time to have a tour in this hospital. I introduce Dr. Shell to start this function. Thank you.
Thank you. He has vast experience of about 18 years in the field of cardiology with special skills and expertise in invasion cardiology. He has an illustrious professional career of working with the prestigious organizations, viz. Indraprastha Apollo Hospital, New Delhi, as advisor in cardiology to the Ministry of Health, Mauritius, and as cardiologist with Department of Health, Dubai, in Rashid Hospital. His latest portfolio was head of cardiology department and interventional cardiology in Medcare Hospital. Dr. Mittal has been granted the memberships of large international societies, which include Fellowship of the American College of Cardiology, the FACC, and Fellowship of European Society of Cardiology, FESC. He holds a number of publications to his credit in reputed international journals, besides being part of research trials and registries. Dr. Mittal is a member of International Advisory Board of Indian Journal of Cardiology and regularly participates in international conferences of cardiology and has been honored as the faculty member many times. He has presented complex cases and other papers in large forums in Paris, Las Vegas, Barcelona, New Delhi, Ahmedabad, Johannesburg, Seoul, and Dubai. Dr. Mittal's main area of interest is invasive cardiology, especially primary and complex coronary angioplasties. I will not take pretty much of your precious time, and I want just to invite Dr. Mittal just to give us our invitation.
Your spirits and your encouragement keeps me away aloft to deliver some important messages in each and every meeting. And I will try my best to deliver the same goods today. And before going into further details away from the topic, I will straight away come down to the topic of presentation today, which is a very, very simple topic but very important topic: evaluation of chest pain. The objective of this presentation is to assess the patients presenting to the hospital with acute chest pain in order to rule in or rule out the acute coronary syndromes. So what's the problem? Patient comes with a chest pain. What's the problem? Why should we so much worried about the chest pain? This is a common presentation. It needs early recognition, it needs appropriate treatment, and we know that errors occur on either side. Somebody not having acute coronary syndrome, somebody not having serious problem, we can label him like that, or otherwise somebody having a really serious problem, we may send him home saying that everything is fine. It is known that 3 to 10% of acute MI patients are actually mistakenly discharged from the hospital. And on the other hand, there are always several unnecessary admissions. So a careful and planned strategy is required once you receive a patient with acute chest pain. And the challenges are patients presenting with chest pain who have life-threatening underlying disease often look well on initial presentation. You feel patient walks in, you feel patient is fine. His BP is good, his pulse is good, it's just a little bit of chest pain, we can give one Alphen and send him home. But that's not the idea. They may look well, but there may be something very important inside. It is estimated that 8 to 10% of patients presenting with ACS who are discharged mistakenly from the emergency department have 30-day mortality of 2%, which is quite high. So we cannot afford to miss out the serious patients, and we cannot afford to send them home saying that everything is fine. So in the evaluation of cardiac chest pain, there are 3 crucial elements, and these elements are the backbone of our further journey in this talk: suggestive symptoms, ECG, and biomarkers. So the whole exercise depends on these 3 factors. The patient comes with the chest pain, he is admitted, the working diagnosis is acute coronary syndrome. The ECG, I'm sorry you can't see that, that is written ECG. ECG can show us 3 different patterns. There can be persistently elevated ST segment, and that patient straight away is labeled as ST elevation MI. The second category, there are some ST and T wave abnormalities, and that patient may be suffering from non-ST elevation MI. And the third category is undetermined or undiagnostic, non-diagnostic ECG or normal ECG. So here is the problem: normal or undetermined ECGs which are not very clear what to do with them. These figures are very important. These are the latest guidelines. The turnaround time for the ECG should be 10 minutes. 10 minutes in the emergency. The patient comes to you with acute chest pain. Within 10 minutes, we should have an ECG available with us. And draw the blood sample, and within 60 minutes, we should have troponin or other cardiac biomarkers available with us. We are talking of the results. The results should be available at 60 minutes at the time of arrival. And it is important to note that there is rise, as, and, or. This is an important word. There is a changing trend in troponins is important to look for. The troponins or the biomarkers should be either rising, should be falling, but if they are constant over a period of time, that we may question the diagnosis of acute coronary syndrome. It is also important to note that currently in the current guidelines, echocardiography is a standard part of the evaluation of the patient with chest pains, because it gives us important information which will be seen in the further slides. Let us go with this actual case. 43 years male, chronic smoker with recurrent chest pain for 1 week, severe continuous chest pain early morning hours on that day, and he presented to the ER in the evening after 12 hours of the severe persistent 15 minutes chest pain episode. He was still having mild intermittent pain but not severe. Hemodynamically and other vital signs were all stable. Now my question to you is, what do you make out of this? Is it highly suggestive of ACS? It is somewhat suggestive of ACS. It is not suggestive of ACS. What do we make out of this presentation? Can somebody volunteer? ABC based on the history. This is the history. Intermittent pain for 1 week, severe pain early morning hours, came in the evening, still having some pain. What is your idea? Is it highly suggestive of acute coronary syndrome? Is it somewhat suggestive, or it is not suggestive? I would say that it is highly suggestive of some cardiac element or acute cardiac chest pain. So next step is we do the ECG. Now here is the ECG. Look at it carefully. I tried to search into it, but it was all normal. Absolutely normal ECG in a patient who is having pain for last 1 week. All right. We repeated the ECG after 3 hours as per the protocol. There is nothing. It is still normal. I told you in the beginning that for chest pain evaluation we need to have 3 things: symptoms, EKG, and biomarker. ECG is normal. And then, as per the recommendation, a 12-lead ECG may not be sufficient for diagnosis. We may need to do posterior leads. So we did V7, V8, and V9 posterior leads. Again normal. And we should also do the right-sided chest leads. So we did even the right-sided leads. Again normal. Everything is normal up to now, except the symptoms. Should we send the patient home? We repeated the ECG next morning. There is hardly any change. There is hardly any difference from the previous ECG. So this is a limitation of diagnosis. That is why. Now my question from you again is, what do you make out of these ECGs? Are they suggestive? Somewhat suggestive? Not suggestive. And you will agree with me that these ECGs are not suggestive of any acute coronary syndrome. Should we stop workup here? No, because we have to go for the third element, which are the cardiac enzymes. Even at the time of these were markedly elevated, troponin was quite high, CKMB was quite high, and next morning the troponins went up further. So do not depend on one single factor. Helpful, and raised levels are also prognostic. There are so many people think that once they do troponin, everything is fine. You know, if troponins may remain elevated or may rise even in many other non-cardiac. That is why I am keep repeating the word rise and fall is important. If a patient comes to you complaining of chest pain, ECG is normal. You do troponin, troponin is high. You repeat troponin after 12 hours, it is same high. You do next morning, it is same high. Then I am a bit skeptical. This troponin is not from heart. This may be due to any of these number of causes. For the heart, either it should continue to rise, or there may be some variation, it should fall. If it remains constant, it is a chronic false positive troponin. So remember that troponin alone may not be diagnostic. That is why I always say 3 things: ECG, symptoms, and biomarkers. So, but in general, troponins are the backbone of diagnosis today. They are the biomarkers of choice for the diagnosis of MI. And diagnosis of MI should be based on a rising and or falling pattern of troponins, and any type of injury, not just ischemic injury, can result in rise in the cardiac troponin. What is high sensitivity troponin? You will keep hearing about it. This uses same antibodies for assays, but it can accurately measure 1/10th levels also. Very minute rise. High sensitivity troponin is not a different troponin. It is only the method of measurement that it can detect very minute amounts of troponins, up to 1/10th of what we can measure with our normal standard method. So, this high sensitivity troponin, normal troponin typically rises and seen in with the normal assay method is 3 to 6 hours, but high sensitivity troponin assay is more likely to detect a rise even much earlier. That is the importance of high sensitivity troponin T. And this allows us to have a rapid rule out. If you do troponin, high sensitivity troponins once at the time of arrival and second is at 3 hours and both are normal, then you can safely say that patient is not suffering from cardiac ischemic injury. So, in our hospital, or I suppose in most hospitals at the moment, high sensitivity troponin is not available. We are doing the traditional troponin, so we have to wait at least until 6 hours before declaring that troponins are fine and cardiac ischemic injury is not there. It allows us, high sensitivity allows us earlier diagnosis, earlier rule out of myocardial infarction. It also allows to detect patient with small MIs that may previously have been discharged, but on the other hand, this leads to a very high degree of false. The patient comes to you with chest pain, you check the high sensitivity troponin, it is high. If it is normal, 2 times, 0 hours, 3 hours, you can send the patient home. If it is high, then you have to take some action. But this high sensitivity troponin may be false positive. It is, and a number of times it may be false positive, and it may lead to unnecessary further. So that is the limit. A word about CKMB. It starts appearing almost at the same time as the troponins, the traditional troponins, peaks at 18 to 24 hours. It also shows about myocardial necrosis. Serial blood samples allow us to see serial rise. 24 hours, patient has an MI after 2 days, you will have fresh rise of CKMB. That is the advantage of CKMB. People sometimes do myoglobin. Even we have a triple card test here which include myoglobin. It is earliest to appear but quite non-specific. That is a limitation. That is a real limitation. So we have a number of limitations with the biomarkers, and an ideal biomarker, if you think, should be give us a quick rise, should be able to detect even unstable angina. This is what actually, and there is nothing ideal in the world. On this biomarker, it is not yet approved. It is not yet. It is available commercially now, even in Dubai, but it is not yet put in the guidelines. It is not approved to be used on an everyday basis. This is known as heart fatty acid binding protein. It is a small unbound cytoplasmic protein with a very low molecular weight, and it's 20 times more cardiac specific. And although it was initially discovered in 1988, progress has been hampered by poor methods of analysis. That was the main problem, and that still is, but yet it is now available commercially. It is a biomarker of not complete necrosis. Even minor ischemias can give rise to heart fatty acid binding protein. That is the advantage. Comes to you with negative HS troponin, but still we should look little further. So the complementary biomarkers will provide us a better yield in terms of missing the diagnosis. There is a concept which is in vogue now, chest pain units. So people just don't depend upon the ER. They have a separate, large hospitals have a separate chest pain clinic. Any patient with chest pain is in there, and there is a protocol which is followed. So these are quite popular these days, which provide early triage. These are fast track protocols. They have a quick rule out MI protocols. We can understand. We have specialists in everything. So why not in the ER? Why not in the ER? We have gastroenterologists, we have cardiologists. No single doctor deals with all the patients. So similarly in the ER, why should ER doctors be dealing with the problems of surgery as well as problems of medicine and cardiology and gastroenterology? So, and because chest pain is such an important symptom, there is a specialized team, a specialized room, patient comes with chest pain there, gets a quick fast track assessment, either rules in and rules out as acute coronary syndrome. So now once again we come back to that, how do we define acute coronary syndromes? There are major anginas and MIs, and MIs are of two types, non-ST elevation MI and ST elevation MI. What is common about acute coronary syndrome? Why these three things have been put together? Why these are under one umbrella? Because there is a common denominator. There is a common substrate for acute coronary syndromes, and that is what you know as the plaque rupture. A plaque which is stable becomes unstable, it ruptures, it ruptures like a volcano, it attracts thrombus, and it leads to a cascade of thrombotic phenomena. Unstable angina, non-STEMI, STEMI. These three have this common substrate. That is why it is important to deal with them quickly and early. Unstable angina and non-ST elevation ACS are commonly caused by partially occlusive and platelet-rich thrombus. For your understanding, I have made this table specially to guide you and to differentiate between STEMI and non-STEMI. You will notice here, if ST segment is elevated is STEMI, no ST segment elevation is non-STEMI. This is by definition. If you go further down, in STEMI we frequently have total occlusion, while in non-STEMI we have subtotal or partial occlusion of the artery. In STEMI there is usually fibrin-rich or red thrombus. It is principally platelet-rich or white thrombus. Markers are elevated in both by definition, because that is how we define that patient is suffering from it. In STEMI mostly you have QAs, but there may be otherwise. In non-STEMIs QAs may be there, but mostly these are not. Revascularization should be immediate in STEMI patients, and in non-STEMI it depends. You can take your time, you can risk stratify the patient. Wall motion abnormalities are always present in STEMI. They may be present in non-STEMI but may be normal. Patient with non-STEMI may have absolutely normal echo, good pumping and functioning heart, and is still suffering from non-STEMI. So non-STEMI diagnosis is more clinical diagnosis and biomarker based diagnosis. Mortality, we think that STEMI has high mortality. Yes, it has high mortality, but in the early phase. While non-STEMI is not without complications. In the later part, the non-STEMI is finally has got as high mortality as STEMI. So non-STEMI needs as much respect as STEMI. So very simply we can put it in this small chart. If a patient with ST elevation MI, he will have wall motion abnormality by echo and the markers will be raised. In a patient with non-STEMI, echo will be normal and markers will be raised. In the unstable angina, the echo will be normal as well as the markers will be normal. So in unstable angina you will be mainly clinical suspicion, and maybe you can pick up in the ECG sometimes. Echocardiography is now a standard of the part of the protocol. It was not before, but believe me and remember always, if you are dealing with a patient with ST elevation MI, do not wait to see the echocardiography. Do not wait to see for the cardiac enzyme. Just go ahead and treat the patient. This is the rule. But in general, when there is not diagnostic ECG, you are not confirmed what you are dealing with, it is always good to do echo for several reasons. And other imaging modalities may help, nuclear imaging. Once and even now, in many centers in the world, nuclear imaging is stationed in the emergency room. When you are not able to diagnose ACS in the emergency room, you send the patient next room for nuclear imaging. So this is one of the components of the evaluation of chest pain. You do myocardial perfusion imaging, look for the new perfusion defects. Similarly, it is now recommended that low to intermediate risk patients should have a coronary CT done. And then if patient is absolutely fine in terms of biomarkers, in terms of symptoms, in terms of ECGs, then patient, you may put the patient on exercise treadmill after certain 12 to 24 hours or even pre-discharge. So this is a list of chest pain which could be non-cardiac and cardiac with different components in different ways, what all you can see there. There are some representative ECGs like this ECG, acute STEMI. Patient comes with 1 hour chest pain. This patient needs a quick early action rather than waiting for cardiac enzymes and rather than waiting for an echocardiography or chest X-ray for that matter. Do not send this patient for his routine chest X-ray evaluation. The patient for chest X-ray because this should be done in every patient. No, just act on this. Act on the ECG. Patient with non-STEMI is frequently present like this. You will see that there is ST depression. There is significant ST depression in lead V3 to V6. This is an actual patient whom I dealt with about 3 months before. You will see that there is a blockage here in the artery, and we had to take him to the cath lab, and we opened this artery up, and the patient was fine in a few days. You may have such dreadful ECGs with you, acute STEMI. The treatment of choice for STEMI is all you know is primary PCI these days. It is no longer thrombolytic therapy. Thrombolytic therapy only if you are not able to provide primary PCI. So this patient, the last one, this ECG, and this is the angiography of the patient. The LAD artery is totally cut from here, totally cut. There is nothing seen. And this is which did not take more than 20 minutes, believe me. Since the time of giving the local injection until it took only 20 minutes. Heavens changed in 20 minutes, this 20 minutes. Patient survival is improved, patient symptoms improved, patient prognosis improved, everything improved. So primary piece, early recognition of acute STEMI and early revascularization are very, very important. So ladies and gentlemen, the conclusion is generally very simple. It is chest pain is one of the most frequently encountered complaints in both the inpatient and outpatient settings, and is a significant financial burden on the entire healthcare system. Clinicians must be able to rapidly and accurately assess a patient with chest pain to maximize patient outcomes and minimize unnecessary workups. The evaluation of chest pain requires good history and physical examination without wasting time. ECG, chest X-ray maybe if you suspect pneumothorax, if you suspect acute pulmonary embolism, and few other diagnostic tests according to the history. But if you are clear that this patient is having clear-cut ECG of MI, deal with like an MI. So we say that ignorance is bliss, but not in the matters of heart. Thank you so much.
Well, thank you, Dr. Mittal, for your comprehensive and nice presentation. I'd like to pass the question to the floor. If there is any question for Dr. Mittal, you are more than welcome.